Something a mentor of mine said many years ago really stuck with me, and I'm paraphrasing here, but it was along the lines of clinicians are keen to point out the 5 or 10 or 15 things that point to a diagnosis, and they're keen to ignore the signs and symptoms or the other facets that do not prove that diagnosis, that actually disprove it. And he encourages clinicians, and he encouraged me when I worked there, to look for the things that disprove what you're thinking. Ask yourself what could happen or what would need to be present for my hypothetical or provisional diagnosis for this patient to be wrong. And sometimes in orthopedics, it's quite obvious. An ACL ruptures in a basketball game, or there's a car accident. But most orthopedics are not due to trauma, at least recent trauma, where the kind of diagnostic picture, especially if it's an urgent emergent situation, is relatively straightforward. So clinicians need to be amassing as much data as they can and know how to synthesize it in order to arrive at the correct diagnosis. What I think improves my diagnostic process is, of course, adding repeated movement testing to my orthopedic evaluation. But think of it this way. If a patient says, I have a runny nose, I'm sneezing, I have a small cough, and I'm much more tired than usual, we would think that that person has a cold, and rightly so. But if that person's also reporting that their eyes are bleeding, that wouldn't point to a cold. And how would you know that? Well, if we just pretend you can't see the person, you only give them a questionnaire, and the questionnaire is very specific and like kind of closed questions. What's going on? Do you have a cough? Do you have a runny nose? Do you have a stuffy nose? Are you congested? Are you fatigued? But they never say, are your eyes bleeding? Well, then of course you're not going to get the full picture. So that's an extreme example, but it's my job to know what questions to ask, because I know that patients usually don't care that if I ask them about their current knee pain and they had hip pain on the other side 8 months ago that lasted for 3 weeks and then went away. I think that's a very relevant piece of information for most patients. And so I need to know the questions to ask. The onus is on me as a clinician to collect the correct data through my specific verbal history, through the orthopedic baselines, and through the repeated movement testing. So here's an example. All the criteria are met for an elbow tendinopathy on the lateral elbow for the wrist extensors, yet there's an extension loss of range of motion. Well, that doesn't fit with the tendinopathy. And so because I know what a joint derangement is, because I've studied this a lot since graduating from DPT school, and because I had to learn it on my own because I wasn't taught it in DPT school, because I had this concept of joint derangement in my mind, then I'm starting to explore that in my diagnostic process, because I don't expect a tendinopathy, especially when the tendon's on slack, to have a loss of range of motion. And so I think clinicians ignore signs like that that don't corroborate the diagnosis they think they have, either because they don't know what else it could be, or they just kind of aren't very inquisitive and they're just like, oh, well, you're also missing elbow range of motion. That sometimes happens. And maybe it does, but I would argue that mostly it doesn't. And so if you don't understand how joints work, you're going to incriminate something like a tendon or fascia or something else that's not at the root cause of what's going on. Similarly, if you diagnose someone with a patellar tendinopathy, they should not be missing knee extension range of motion. The tendon's on slack. Maybe they're missing flexion, but I would expect if they're missing flexion for the knee, that it's because it hurts in that tendon and it's on stretch. But if the knee is just obstructed into flexion without pain, well, then that doesn't make sense for the tendon, because the tendon is extra articular. It's outside the joint, so it shouldn't obstruct movement. There's lots of examples like that. If you talk about a specific verbal history, say someone thinks they have an Achilles tendinopathy, and lots of the signs and symptoms point to that. Yet when I ask the patient, they say that the pain started in the buttock 5 months ago, then into the hamstrings, then they had really bad calf pain last month, and now it's just kind of like mild pain in the Achilles. Well, that doesn't sound like an Achilles tendinopathy to me. That sounds like something from the low back. So again, the burden is on me to ask the right questions, knowing more or less how the body works. And that's my job, to understand how the musculoskeletal system works. So to go back a little bit, joint derangement is what I find in 70 to 80% of patients. And it really fills in those holes for all those diagnoses orthopedic clinicians are coming up with where all the pieces of the puzzle do not match that diagnosis. So joint derangement, by definition, is a mechanical problem with the joint mobility that causes local and or referred pain. It has limited and or painful range of motion that in the extremities is observable. And in the spine, it's almost always observable to the naked eye, but the spine can be a little bit trickier just because you have so many vertebrae and so many intervertebral joints moving at one time. It can create nerve tension possibly, and it can create muscle weakness, meaning muscles test weak, but that would reverse quickly. And again, by definition, you have to meet those criteria for the joint derangement diagnosis, and you have to fix that by all those signs and symptoms that are there by moving the joint repeatedly into one direction. And we call that directional preference. And sometimes it's 2, and in rare cases it's 3, but it's almost, it's usually one movement that we just have to find. Is it neck retraction in sitting? Is it neck retraction in supine? Is it knee extension in standing? Is it plantar flexion in loaded? The directional preference is the movement, so to speak, that gets that joint back on track. And so all those signs and symptoms just fade away. But in a similar fashion, I call these 5 the big orthopedic stories. Femoral acetabular impingement syndrome, greater trochanteric pain syndrome, subacromial impingement syndrome, IT band syndrome, patellofemoral pain syndrome. And I think these are convoluted ideas about pathophysiology. And the reason I'm highlighting these today is because there isn't one great explanation of these as a diagnosis. Because I used to diagnose people with these all the time. I was taught these as part of my doctoral program. And the problem with these is because there's not a great cohesive definition, clinicians, even if they find something that doesn't seem relevant, will just say, oh, well, in some people that happens. Like in patellofemoral pain syndrome, oh, sometimes you're missing knee extension, right? Or sometimes knee flexion is obstructed. Or sometimes you have this and your low back is also lacking range of motion. They can take anything that they find and make it just fit because there's no reliable, agreed upon definition of these things because they're basically defining pain, right? Which is a symptom, not a pathophysiology. So I don't find these in patients anymore. Maybe I'll be stumped and one day come to the conclusion that one of these actually exists. But instead of these kind of ambiguous terms where anything goes, right? Oh, you have greater trochanteric pain syndrome because your abductor on this side is weak and the other one's tight. And yeah, your low back is missing some range of motion, but that may or not be relevant. They just go through all these things that you're going to look at different patients with this diagnosis and find very different clinical presentations. And yes, in joint derangements, you're going to find different clinical presentations because, as I mentioned, limited and or painful range of motion of the joint. It could be, abduction in someone and flexion in another person. But the definition of joint derangement, as I've just spelled out, is pretty strict. Because if I don't see a change with repeated movements quickly, then I don't have a joint derangement. So it's based on the clinician being able to apply the appropriate testing. But for these, they're kind of just more wishy-washy. For some people with IT band syndrome, we need to strengthen the abductors. For some people, we need to work on the hip flexor. For some people, we need to focus on the VMO. It just doesn't have that cohesive picture that I would like when we actually give someone a diagnosis, because of course having the diagnosis informs the care. And so if we're not getting the right diagnosis out of the gate, we're not seeing great care. And I think that's borne out. If you look at the research that talks about outcomes with these, they're not stellar. And so I would say for almost all of these cases, we have to look at a diagnosis of joint derangement. For here, if it's going to be the low back or the hip, or maybe even the SI joint. For here, kind of same thing. For the shoulder, it's going to be look for a derangement in the mid back, neck, or shoulder. For the IT band syndrome, it's going to be look for a derangement in the low back, hip, or knee. And for patellofemoral pain syndrome, it's going to be also in the low back or knee, and maybe sometimes in the hip. But we need to understand that if we find something that's not in what we think or are told is the clinical picture for a diagnosis, we need to really start to think what else this could this be? And I'm proposing to clinicians who haven't learned repeated movement testing that by learning Mackenzie's repeated movement testing, you'll start to see that these things do make sense. And furthermore, when we think of the body, there's only so many different pathophysiologies or pathoanatomical lesions that can happen. And so it makes sense where it's consistent, whereas most people are getting tweaked joints, some people are getting tweaked tendons that are tendinopathies, and then there's a smaller cohort of people that are getting any number of different things that are quite rare in comparison to joint derangements and tendinopathies. We need to really understand a diagnosis to be able to apply the correct care, and I think by adding the concept of joint derangement to orthopedic care, which is what I hope we end up doing in the musculoskeletal world in the United States, we will find that there's consistency and reliability with our diagnosing because all the pieces of the puzzle will actually fit.